Welcome to the NWAETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to our speaker for the talk today.
Great. Thanks, everyone, for inviting me to review some of the new data on hepatitis at the recent CROI. I was telling Brian that there were over, I think, 85 abstracts on hepatitis, and it's always a challenge to pick like 3 or 4. But I did, and I think I picked the ones that I think kind of illustrate a theme, which is that we have made tremendous strides, as all of you know, in just drug therapy, the efficacy of drug therapy, and that some of the challenges we face now, and in sharp contrast, is how to really provide effective delivery and implementation of this therapy. So without further ado, the first is really illustrating how far we've come. So this was the study that we were all waiting on, which is the ION-4 study, looking at ledipasvir sofosbuvir for 12 weeks in hepatitis C HIV co-infected patients. And I thought it was interesting, as a side note, that the session in which this oral abstract was presented was entitled Curing HCV, Mission Accomplished, which I thought was really funny because I didn't know whether it was being cheerfully optimistic or overly self-satisfied and premature. But in any case, the ION-4 study was a single-arm trial that looked at ledipasvir sofosbuvir, which, as you guys know, is now on the shelves and approved for mono-infected patients. And they enrolled folks from the US, Canada, and New Zealand, and they were fairly broad in their inclusion criteria. They included naive and experienced patients. They included a sizable chunk of compensated cirrhotics. And their HIV inclusion parameters were mainly they wanted the patient suppressed, and their CD4 counts had to be greater than 100. And if you'll note, this is a lower threshold than what historically have been the case for co-infected trials because we're not using interferon. And the ART regimens that they allowed were Truvada plus one of the following: efavirenz, raltegravir, and rilpivirine, which are the agents that have minimal drug interactions with the ledipasvir sofosbuvir. So these were the study characteristics. So you can see the age range was fairly broad. The mean age was 52. Most of the patients were men, as is the case in most co-infection studies. A sizable proportion of these patients were Black. 34% were Blacks, so I was gratified to see that. 17% Hispanic. And in keeping with that racial distribution, there was a moderately high proportion of less favorable IL-28 genotype, CT or TT. The vast majority of the patients were genotype 1. I think they only had about 7 or 8 patients who were genotype 4. They did allow a few 4s into the study. And 55% were treatment experienced. And these were folks that had seen protease inhibitors as well. So they had either failed a PEG ribavirin and telaprevir or boceprevir-based regimen. And I believe there were about 29% of them who were PI experienced. And 13% had actually failed sofosbuvir ribavirin. So it really included the mix of treatment experienced folks. And 20% were cirrhotic. Most of these folks, despite the generous CD4 count inclusion, had very high CD4 counts. The median was about 630. And you can see the distribution of the ART regimens. Basically, it was mostly divided between folks who were on Atripla or Truvada plus raltegravir. So these were the results. So these were the sustained virologic results 12 weeks post-treatment. Overall rate was 96%. And you can see the response rates broken down by whether or not they had cirrhosis. And you can see cirrhotics did very well. And whether or not they were treatment experienced or naive. And I will note that the classically treatment refractory subgroup of folks who were treatment experienced and cirrhotic, there were about 46 of them, I believe, had an SVR rate of 98%. So really pretty phenomenal. So when you looked at adverse effects, you see that the serious adverse event rate was really quite low, 2%. No one stopped treatment due to adverse events. And the more common side effects that were encountered were headache, fatigue, and in our clinical practice, those two are the most common side effects, and they range anywhere from like 15 to 25% of patients, usually manageable. Diarrhea and nausea in a lower percentage of patients, more like in the 10% range, and then arthralgia in a small percentage, and upper respiratory infection, which may not have been related to the medication. I will note, and we'll discuss this probably in the Hep C co-infected case, that there is a drug interaction with tenofovir and ledipasvir. So ledipasvir will increase the levels of tenofovir, and there is, on the package label, they do caution against using boosted PIs with tenofovir for that reason in these patients. In fact, they advise against that combination. So you'll notice that none of these patients were on PI-based regimens for that reason. There were only 1% of patients who had a significant change, which they pre-specified as a creatinine increase of greater than 0.4. So really low rate of change in that regard. So Susanna Nagy actually presented the subgroup analysis looking at, so these are all of the patient characteristics that have traditionally been associated with influencing treatment response rates. And the only thing that really stood out was black race. And I found this really interesting because all 10 patients who relapsed, so it was a 96% rate, and the 10 patients who relapsed, all of them were black, which is a striking difference actually from the other ION studies. So ION 1, 2, and 3, which were the mono-infected registration trials for ledipasvir, sofosbuvir, did not see this difference. And I would caution against saying that because of that there is no difference, because really they may have been underpowered to detect a difference with respect to black race. All of those studies really had a low proportion of black patients. It was not nearly as high as this one. As I mentioned, it was 34% black patients in this study. In the ION studies, the average was about 10%. But if you pooled the ION 1, 2, 3 data, they didn't really find that black race predicted higher relapse rate, as is the case in the ION 4 study. So I think this is going to be interesting and something to note. It was discussed after this abstract was presented, and I think in the end, and Susanna Nagy talked about the fact that they did some sub-analyses looking at pharmacodynamics, in case that played a role. Turns out that drug levels were really comparable. There wasn't really concerns about adherence based on these patients, at least from what we can always glean from trials. So it's a bit of a mystery, but my take on this is that, it's clear that HIV infection is not really influencing treatment response anymore, but it does make me wonder if, HIV infection plus maybe a TT IL-28 plus black race may influence in some patients. So something to keep in mind. So this is a reminder of where we've come in terms of milestones with Hep C treatment. You can see that in the PEG interferon era, there was this classic treatment gap between mono-infected patients and co-infected patients that we saw narrowed in the era of introduction with these new direct-acting antivirals. And we're now here in 2015 with interferon-free direct-acting antivirals. We're really looking at 96% SVR rates plus. So it's clear that we've really crossed the threshold with respect to treatment efficacy. And now it's a question of how to get these drugs to the people who need them. I want to talk about the next abstract I wanted to talk about was a really interesting modeling study that was presented by a Swiss group looking at the impact of deferring Hep C therapy in co-infected patients. So as many of you who have been prescribing some of these meds know, the most challenging thing about this whole process is actually getting the drugs for our patients. And there have been, particularly given the price of these medications, there have been parameters and hoops and restrictions laid out by insurance. Here in Washington State, as is the case in many other states, the Medicaid plans have pretty much said that it's patients with stage 3 and 4 that they're going to authorize or pay for the medications. And so what this group did was, okay, let's play out this scenario and see what happens when we actually decide to defer patients to stage 3 or 4. And they compared multiple scenarios in their models. So they compared a historical, what we used to do with PEG ribavirin, looking at the PEG ribavirin era, where we were a little less restrictive about stage, but had less uptake. And then looked at playing out a scenario, what I would call the best case scenario, where we started DAAs very early, within a month of Hep C diagnosis. And then what happens when you start it within a year? And then what happens when you start at stage 2, 3, and 4? So they looked at outcomes of decompensated cirrhosis, cancer, liver cancer, and liver-related death. And they also looked at the period of infectivity, which I thought was interesting, and I think we need to look at more, particularly as we're shifting to thinking of, as these drugs become more tolerable, thinking about treatment as prevention. And they made a number of assumptions, which is that successful Hep C therapy would result in a 10-fold reduction in liver fibrosis progression and the risk of decompensated disease, and a 2.6 reduction in HCC. And this is based on established data in the literature. And they also made some additional assumptions about the percentage of uptake of PEG interferon ribavirin with a cure rate of about 40% on average, higher uptake with DAAs, and a higher cure rate. And so this is how basically these were the results. As you can see here, you can see that in the historical, so historical is the white bar, that's the PEG-RIBA era. You could see the rates of cumulative probability of cirrhosis, HCC, and liver-related death. And you can see here that as you defer therapy further along, the more advanced fibrosis you wait for, the more likely you're going to encounter HCC and liver-related death. And this is something that we all would expect intuitively, but it was really helpful to see this illustrated out. And I thought particularly helpful to see it in terms of average time of infectivity, that you go from deferring therapy for a year after diagnosis to waiting until people are stage 4. So we're talking about over 20 years of infectivity in this situation. So something to ponder on, certainly, as we argue with insurances about their decision making on some of these issues. The other abstract I wanted to talk about was looking at kind of where we've come with end-stage liver disease in co-infected patients. So this was actually a poster that I was part of. So one of the things we've learned from natural history studies of patients with viral hepatitis is that having HIV can accelerate the disease progression. It's clear we've come a long way in terms of more effectively managing the HIV and treating people earlier. So one of the hypotheses that were raised in this poster was, what are the temporal trends in end-stage liver disease, which is a fairly rare event but very devastating. And we wanted to, ask the question, has safer, more effective, modern antiretroviral therapy reduced the rates of end-stage liver disease? And these end-stage liver disease outcomes were pretty rigorously validated through the NA Accord. You guys may be familiar with this. This is a very large collaboration of North American HIV clinical and interval cohorts. And the bottom line is, well, it doesn't really look like it has changed significantly. So you can see here, this is looking at the incidence of end-stage liver disease per 1,000 person years for people who don't have either hepatitis B or C. Folks who are Hep C co-infected, Hep B co-infected, and then have the misfortune of having both chronic Hep B and C. And you can see here that the rates of end-stage liver disease are several-fold higher, by a factor of 7, when you have either of these, and certainly if you have both. And you can see that the confidence intervals are fairly wide because this is a rare event, but you can see that they really haven't changed substantially, especially for hepatitis C. There might be a suggestion that in the modern ART era, as more of us are using Truvada in our patients, the incidence might have come down, but it was not statistically significant in the Hep B co-infected group. But the message I took away is that there hasn't really been as much change as we would have hoped. And part of that may be that we need more numbers to look at this, but it was certainly food for thought. So it's clear that we need directed therapy for hepatitis C and B. I will breeze very quickly through the last abstract, which is really looking, this was a group from DC that had a very large, this was like a collaboration of 13 clinical sites in Washington, DC, and they sought to characterize the burden of hepatitis C in their HIV group, and to look at risk factors for disease progression and eligibility for treatment. So you can see here that in their, they had, I think, over 6,200 patients and a prevalence of hepatitis C of about 15%, which is on par with what we see nationwide. And what was interesting is that in the few years of follow-up they had, they actually picked up hepatitis C in about 200 patients. So in about just under 4% of their patients, they actually had incident hepatitis C. And they looked at the characteristics, and there are a couple of things that stood out for me. One is, you can broadly generalize and say, oh, it's the DC Baltimore area, it's all injection drug users that must be having incident hep C. Well, that's really not the case. If you look at the incident hep C group, it turns out that the majority of them really had, their risk group was mostly sexual, and 20% certainly had injection drug use, but it was certainly not the majority. The other thing that you'll note, and this is something we see again nationwide, is that there's a preponderance of publicly insured patients among those who are co-infected. And then, of course, a trend toward higher mental health comorbidities. This was, I think, the take-home message, which was that when they stratified, those of you guys who may be familiar, the American Association for the Study of Liver Disease and the Infectious Disease Society has come out with guidelines about prioritizing who should we prioritize for treatment, and they come up with categories. I think John Scott has gone over this. The highest priority really based on disease, high priority based on other moderate disease and other cofactors that might accelerate liver disease progression. And then they have a category called elevated risk of Hep C transmission, where we should really think hard about whether we really want to treat this person. And you could see that it turns out among the 293 patients who were untreated that they looked to see what kind of parameters they had. Sizable proportion met advanced fibrosis criteria, 22%. And if they didn't meet that, the rest of them actually met it in terms of stage 2 or above. And then a sizable proportion fell into groups where they would be at risk for Hep C transmission. So in the end, over 86% of these untreated Hep C infected patients met at least one AASLD IDSA priority criteria for treatment, which I thought was really interesting to see it kind of laid out in a very sort of an urban, co-infected cohort. I will say briefly that we'll have room for a few questions, but I would really encourage you guys to check out the Bernard Fields lecture. This was one of the first plenary sessions. It's on the CROI webcast by Dr. Charles Rice, who's one of the leading virologists based at Rockefeller University in New York. It was one of the best talks that I've seen on hepatitis C in terms of really taking us through the virology and the advances we've made to where we've come in terms of drug therapy. And one of the things I thought he really laid out was, unlike the title of the oral abstract, it was a very tempered talk. He talked about the challenges that we face before us, and it outlined the fact that we have some gaps to cross.